The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hi, good day. I'm Dr. Rubio, and I will be your teacher for the rationale of the finals exam along with Dr. Gabby Flores. So let's first talk about biochemistry. First day of your exam. Okay? So what is the major mode of heat loss in humans if skin temperature is greater than the environment temperature? Kapag mas mainit ang ating skin than the environment, we have two modes of heat loss that we can utilize. We have radiation and conduction. Pero kapag mas mainit ang ating environment than our skin, ang ginagamit ay evaporation and convection. Now, ang tanong dito ay, what is the major? So, mas major mode of heat loss ang ating radiation than conduction. Okay? So, recall guys, conduction here is only a minor mechanism. Now, another point na kailangan yung matandaan here is humidity. Humidity may affect thermoregulation, especially when we're talking about here evaporation and convection. Okay? Pag heat gain, meron kang dalawang mechanisms. Shivering thermogenesis and non-shivering thermogenesis. As the name implies, shivering. Meron kang chills. Meron kang overall skeletal muscle contraction, leading to heat generation. Pag non-shivering ka, this phenomenon usually occurs in babies of lower mammals. Okay, so wala pa silang enough na skeletal muscle para mag-generate ng heat. So they rely on brown adipocytes. Now, they release a hormone known as thermogenin. Thermogenin is a strong uncoupling agent of the electron transfer chain. And this may lead to non-shivering thermogenesis. Number 2, what amino acid is determined as the 21st amino acid? Now, B and D are part of the 20 original members of the amino acid family. Now, A and C, sila yung mga bagong dagdag lang sa ating listahan. And cysteine is the 21st amino acid, while pyrrolysine is the 22nd amino acid. Okay, pyrrolysine, as mentioned, is the 22nd amino acid. So, this is very important, guys, kasi ang ating cysteine, instead of having the usual sulfur in its structural analog, meron siyang selenium atom. And this cysteine is only formed during translation, but is not specified by a simple 3-letter codon that we usually have in the original 20 members. Number 3, sickle cell disease results from a missense mutation in both genes encoding for the beta chain, resulting in a change from, okay guys, dapat master nyo na to ha, it should be glutamate to valine. Okay? From a glutamic acid, naging siyang valine. Bakit siya delikado at bakit siya very prominent? Recall that glutamic acid is an acidic amino acid. Tapos naging siyang valine, which is a non-polar amino acid. In that sense, magbabago ang conformation ng ating beta chain, leading to a defect in your sickle cell disease. So, ang isa sa ating mga choices na glutamate to lysine is also important kasi this one will lead to the formation of your hemoglobin C disease. Now, for a shortcut, think of this mnemonic. Think of lysine. Lysine, glutamic acid becoming lysine, That is a pathology or the pathogenesis of your hemoglobin C disease. As you can see, it's a point mutation. So remember guys, bakit mahalaga ang ating sickle cell disease? Well, historically kasi, na-develop siya due to malaria. Diba ang malaria, it loves to go to RBCs. Now, kapag nagkaroon ka ng sickling, diba, nagkakaroon ka ng actually na innate na resistance from malaria. However, sickling of RBCs is not good for the body kasi it can lead to occlusion of different capillaries, leading to different problems, including chest pain and even problems with neuro and even in the renal system. Okay? So take note of these concepts in sickle cell disease. Number 4, a 35-year-old female presented with gross hematuria, high blood pressure, and decrease in urine output. On top of it, she has bilateral hearing loss and has opacification of the lenses. What type of collagen fiber is defective in the most likely condition causing her presentation? So look at the lines, the words in red and underlined. That is actually the triad of a nephritic syndrome. You have gross hematuria, hypertension, and having decreased urine output. Initially, oliguria that can lead to anuria. Now, in our case, meron din siyang bilateral hearing loss at meron siyang lens opacification. These are actually added parameters that you can see. And with nephritic syndrome, they form a triad for our disease known as Alport syndrome. Alport syndrome, so siya it's a familial disease actually, wherein pwede ka magkaroon ng hematuria if you're exposed to infection 2 years prior the onset of the problem. Okay? And Alport syndrome is actually due to a defect of your type 4 collagen fiber. So defect in choice A is actually about type 1. Pag type 1, it's all about the bones. Okay, so type 1, we have here your osteogenesis imperfecta. And on top of it, pwede rin ang ating classical Ehlers-Danlos syndrome. Kapag ang defect naman ay type 3 collagen fiber, think of reticular fibers. These reticular fibers are involved in your hypermobility and vascular Ehlers-Danlos syndrome. Now, as mentioned, guys, we have your Alport syndrome. It's a problem of your type 4 collagen fibers. A good mnemonic here is Alport syndrome. Alport syndrome, the problem of the type 4 collagen fiber. So, guys, balikan lang natin yung ating mga collagen fibers. Bone, type 1. Tendon, type 1. Cartilage, type 2. Reticulin fibers, type 3. Basement membrane, 4 is under the floor or 4 on the floor. Okay, stuff like that. And of course, your anchoring fibrils, the one that hooks your basal cells to our basal lamina. It's very important. Okay, and defect of your anchoring fibrils can lead to bullae formation. Number 5, what transporter is involved in insulin-stimulated glucose uptake? It's no other than GLUT4 transporters. So these are your different GLUT transporters. GLUTs 1 to 5 and SGLT1 and 2. Now to differentiate them, take note of the following. First, ang ating SGLT2, 1 and T2 are known as secondary active transport systems. Pero ang ating 1 to 5 is gumagana sila basically with your facilitated diffusion. Ganun siya gumagana. Now take note GLUT4 is insulin-stimulated glucose uptake. Always think here of 2 tissues, adipose tissue and striated muscles. Now what are striated muscles? We have here your cardiac tissue and your skeletal tissue. A good mnemonic here also is your GLUT2. GLUT2 is found in the beta islet cells for pancreas. Beta cells is the second, beta is the second letter of the Greek alphabet. Liver, may GLUT2 rin yan. Recall, you have two lobes of the liver, the left and the right liver. Kidneys, you have two kidneys. GI tract, the term GI has two letters. So recall guys, siya lang ang ating insulin-simulated glucose uptake. Si GLUT4 lang. Number 6, what is the acceptable macronutrient distribution range of simple sugars? Simple sugars, ito yung mga sugars na dinadagdagan lang sa ating pagkain during food processing. For example, gusto mo ng mas matamis na pagkain, you'll add some sugars in it para mas tumamis siya. Okay, so yun yung ating mga simple sugars. These are only performed during packaging and also during flavoring of your food. Now, minsan kasi hindi napapansin ng ating mga consumers ang dami ng ating simple sugars na nalalagay sa ating pagkain. But actually, kailangan should be less than 10% of the total kilocalories. Because increased risk of simple sugars percentage in our kilocalories can lead to problems in the cardiovascular system as well. Also, it can also pose an increased risk for complications for diabetes. So yan guys, take note of these values. The AMDRs for macromolecules, the one in the pie chart, kailangan alam nyo yan. And of course, the one in the table. For your trans fat, saturated fat, your PUFAs, your MUFAs, and of course, your simple sugars. Number 7, what is the earliest sign of vitamin A deficiency? So ang usapan guys ay sign. Ano ba ang sign natin? Sign is what? It's an objective finding. Kasi ang ating symptom ay isang subjective finding. Ang sintomas, yan ang nararamdaman ng ating pasyente. Ang sign, yan ang nakikita mo sa ating pasyente. Therefore, among the choices, alin dyan ang symptoms? Sumukang ang ating C and D ay tanggal na sa ating option. Kasi both of them are symptoms. We're after here a sign. So pili ka na lang dyan. Ano ba ang unang nawawala? Sensitivity to red light or to green light? Now, the correct answer here is actually loss of sensitivity to green light. So vitamin A deficiency is the most common vitamin deficiency worldwide and even in the Philippines. But it's very preventable. Now, ang tawag sa collective signs and symptoms ng ating vitamin A deficiency ay tinatawag na xerophthalmia. Pag earliest sign ang involved for deficiency, it's the loss of green light sensitivity. Pero kapag ang usapan ay sintomas, the first symptom is nyctalopia, also known as night blindness. Now, also take note of the parts of the eye involved in vitamin A deficiency. You have cirrhosis, dryness of the conjunctiva. Pag bitot spots, we have here involvement of the sclera. Pag keratomalacia, involved here is the cornea. Number 8, a 56-year-old male presented with anemia, ataxia, loss of position and vibration sensation, and tea-colored urine. What is the most likely deficient vitamin causing the presentation of the patient? Okay, now so our choices here, alin ba dyan ang walang anemia? So obviously, B, C, and D can present with anemia. So tanggal ang ating vitamin K in the choices. Now we have here ataxia, loss of position, and vibration sensation. So these are neurological manifestations, mostly a defect in the posterior columns. So definitely tanggal si letter D. Vitamin B9 does not present with neurological presentations, leaving us with B12 and E. So halos same sila. You can have your anemia and neuro problems. Pero kasi ang tanong dito, what kind of anemia ang makikita sa B12? What kind of anemia ang makikita sa ating vitamin E? Now you have here tea-colored urine. So tea-colored urine, and if a patient also has jaundice, are actually the clinical presentation of hemolytic pattern of anemia. Especially kapag meron kang unconjugated hyperbilirubinemia. Now, with that said, so mukhang meron kang hemolytic cause of your anemia. So, between the two, vitamin E is the more likely deficient vitamin in our patient. So as mentioned, both have anemia, both have posterior column defects. Pero in vitamin E, recall that it is an antioxidant. So having less antioxidant in the body, in vitamin E deficiency, you will have lipid peroxidation of the cellular membrane. Kapag nagkaroon ka ng ganong pathology, high risk ka for having lysis of your RBC membrane. Now, in the anemia of B12, ang problema dyan is maturation anemia, stemming from a lack of nutrition needed for the development of your RBC. In this case, it is vitamin B12. So you will have here a macrocytic anemia presentation. Pero wala kang mga jaundice, wala kang mga T-colored urine. So C is the best answer here. Okay? Recall guys that A, tocopherol is the most potent form of your vitamin E. And take note guys that B9 and B12 both have reversible macrocytic anemia. But only B12 has irreversible posterior column neurological defects. In terms of laboratory parameters, both B9 at B12 tataas sa kanilang homocysteine, parehong bababa ang kanilang folic acid. To differentiate them, look at the methylmalonic acid. Normal lang ang methylmalonic acid ni B9 pero elevated ito sa ating vitamin B12 because B12 is important for the transformation or conversion of methylmalonic coenzyme A into succinyl coenzyme A. Number 9, what are the components of hyaluronic acid? So as mentioned before, diba? You have to know the components of your glycosaminoglycans. And the correct answer here is A, N-acetyl glucosamine glucuronic acid. So guys, besides knowing the location of your glycosaminoglycans, you also have to know their sugar units. Ito yung mga dadaanan mo bago mag-exam. Okay, a day before your exam, daanan ng konti kasi madali sila makalimutan. Okay? But take note that hyaluronic acid is mostly found in synovial fluid, chondroitin sulfate, chondro, cartilage, keratin, okay, think of keratitis sa cornea natin, heparin coming from mast cells, heparan sulfate in the kidney basement membrane, and dermatan sulfate coming from the skin. Number 10, this enzyme is capable of hydrolyzing the first and third positions of triacylglycerol, yielding 2 free fatty acids and 2 monoacylglycerol. However, it is inhibited by bile acids. The correct answer here is A, pancreatic lipase. So as mentioned, ang function niya is to hydrolyze the first and third positions. So let's say this is 1, 2, and 3. So tatanggalin niya ito tsaka ito. Para natanggal yan, you will have 2 free fatty acids and 1 monoacyl. So 1 lang na fatty acid na glyceride na nakadikit sa ating second position. Kaya siya 2 mag. But take note guys this lipase is actually inhibited by bile acids. So for this to function, you have to have your colipase. Colipase is a bridging molecule that binds the bile acids to the lipase. Pinipilit niya na magdikit ang dalawa para magkaroon ng activity si pancreatic lipase. But without your colipase, hindi gagana ang ating pancreatic lipase. Number 11, spontaneous reactions occur in this condition. It occurs kapag our free Gibbs energy is less than 0. Guys, you have to know this first. Okay, ang interpretation ng ating mga Gibbs free energy, enthalpy, and even entropy. Kapag less than 0 ang ating Gibbs free energy, it will lead a spontaneous reaction. Kapag more than 0 ka, it will lead to a non-spontaneous reaction. Kapag zero siya, it means equal ang ating forward and backward reactions. Take note guys, iba ang interpretation ng ating Gibbs free energy sa ating enthalpy or delta H. Okay? Number 12. Rotenone inhibits the complex of electron transfer chain. Anong complex ang ini-inhibit ni rotenone? Guys, sa pangalan na niya, roten 1. So, the correct answer is complex 1. Okay, guys, don't forget these are very important. The inhibitors of complexes 1, 2, 3, 4. Okay, you have the following. Now, to aid you in memorizing them, take note of this mnemonic. Rotenone 1. Antrimycin is for 3. While ides, yung mga may ides sa atin, carbon monoxide, cyanide, you have 4 letters, di ba? AIDS. So they inhibit the electric transfer chain complex 4. Number 13. What derivative of pyruvate enters the citric acid cycle? Now, ang ating pyruvate, marami siyang derivatives. Okay? And these derivatives will enter different metabolic pathways. Nasa center yan ng ating metabolic pathway. So you have to know this. Okay? So, ang pyruvate derivative that will enter the citric acid cycle is your acetyl coenzyme A. So this is a very good figure in your handout. Pyruvate becomes acetyl-CoA via pyruvate dehydrogenase para makapasok sa ating citric acid cycle. Okay? Take note of the other pathways for the fate of pyruvate. It's a testable concept for the PLE. 14. What is the site of oxidation of very long-chain fatty acids? Now, your very long-chain fatty acids, they have a carbon of more than 22 pataas. Okay? Para ay sila ay ma-oxidize, kailangan mo ng peroxisome. But take note that mitochondria is the site of beta oxidation of most fatty acids. Doon na nagkakaiba sa ating VLCFA. They have to occur in your peroxisomes. 15. What is the rate-limiting enzyme of the urea cycle? Correct answer is A. Carbamoyl phosphate synthetase 1. I asked this kasi nakakalito yung ating 1 and 2. So you have to differentiate them. Baka kasi malito sa ating exam. Take note that 1, CPS1 is for the urea cycle, while CPS2 is used for the pyrimidine synthesis pathway. So guys, take note of these differentiating concepts. Iba sila, baka mahilo, baka ma-confuse. 16. This cell serves as the link between the innate and adaptive immune systems of the body. It is your dendritic cells. Dendritic cells are what we term antigen-presenting cells. They are the major antigen-presenting cell of the body. But we have actually 4 types of, or 4 examples of antigen-presenting cells. We have here macrophages, B cells, Langerhans cells, and of course, the major one is your dendritic cells. Kaya sila naging link between the innate and adaptive immune system kasi they are prominent in the innate immune system and they process the microbes, the foreign body, into antigens. These antigens, iprepresent nila to kay helper T cells, causing an activation of the adaptive immune system. So therefore, nilink niya ang innate system to the adaptive system in this process. Okay? And among the different APCs or antigen-presenting cells, siya ang pinaka-major. So, dendritic cells serves as the link in this sense. Number 17. What is the deficient enzyme that can lead to acute intermittent porphyria? Okay, you have to know the different pathologies involved in the metabolic pathways. Okay, the correct answer here is A. Porphobilinogen deaminase. So guys, medyo memorize to ng konti I believe there are some mnemonics given in the handout. But besides this, you also need to know that glycine and succinyl-CoA are the parent compounds of your heme protein. Glycine, the amino acid, is the parent amino acid of heme. And take note their different clinical features. You can see the first four have neurological problems as well as your congenital erythropoietic porphyria. Okay, moreover, take note of their photosensitivity. May mga blistering dyan, tsaka non-blistering. Number 18. All glycosaminoglycans are covalently attached to a core protein to form proteoglycans, except hyaluronic acid. So, ganito ang ating discard na dyan. A glycosaminoglycan plus a core protein equals proteoglycans. So, it happens in all glycosaminoglycans except for your hyaluronic acid. As you can see, guys, yan, you have here a very, very long image. So, para siyang test tube brush. Yung gitna natin, ang tawag doon ay core protein. Ayan. Ito guys, ito yung ating ito yung ating test tube brush dito. Yan. Yung maliit na part dito. That's a test tube brush. Let's magnify it kunwari. Yan. Yan ang ating core protein sa gitna. Na yung parang mga maliit na fibers yun na blue, those are your glycosaminoglycans. So together, yung hibla na yan, yung test tube na yan, they form what we call a proteoglycan. Now, these proteoglycans, they will be attached to the very, very long hyaluronic acid. Okay, para siyang inception. A test tube brush in a test tube brush. Kung yung kanyang concept dito. But basically, this proteoglycan, it's only involved kapag nag-form ng bond ang ating glycosaminoglycan and a core protein. Number 19. What is the defective repair mechanism in patients with xeroderma pigmentosum? So these are problems in genetic repair. Maraming types yan. And in xeroderma pigmentosum, it is actually the model disease for a problem in nucleotide excision repair. So, okay, you have to know this. Pag ang usapan ay mismatch repair, defect, ang sakit ay Lynch syndrome, your hereditary non-polyposis colon cancer. Kapag nucleotide excision repair, xeroderma pigmentosum. Kapag base excision repair, ang defect, we have your MUTYH-associated polyposis. And of course, we have problems in double-strand breaks. Ang mechanisms dyan, we have homologous and non-homologous recombination. Having a problem with this mechanism can lead to SEID, severe combined immunodeficiency, and can lead also to increased risk for breast cancer. 20. Which is not a stop codon that terminates the process of translation. Again, guys, what we have, transcription and translation. In transcription, the DNA makes an RNA. That is your transcription. Now, transcription, your transcripted mRNA rather, being translated to an amino acid sequence, that is your translation. So to start the translation, kailangan mo ng AUG. Pero to stop the translation, you need to have wa, uga, wag. Okay? That is our mnemonic there. The stop codons, wa, uga, and wag. Again, guys, to start translation, you must have OG, AUG, the one that codes for methionine. Mnemonic ko dyan, nowadays, the start of classes in the education in the Philippines is August, Agosto. Okay? Start of classes, OG. Stop codons, wa, uga, wag. And that is all for your biochemistry.
Hello, everyone. Welcome to your finals exam discussion to be discussed by me, Dr. Gabriel Flores, and Dr. Franz Rubio. So let's start right away, starting with Anatomy and histology. First question, which of the following incorrectly describes the ureter? A, it enters the pelvis by crossing the bifurcation of the common iliac artery in front of the sacroiliac joint. B, the ureter then runs down the lateral wall of the pelvis to the region of the ischial tuberosity and turns forward to enter the lateral angle of the bladder. C, the lymph drains to the lateral aortic nodes and the iliac nodes. Or D, the ureter is approximately 25 centimeters in length. So our answer here is letter B. So remember, the question stem is asking for which of the following incorrectly describes the ureter. So A, C, and D are all correct, whereas B is incorrect. So why is letter B incorrect? The reason it's incorrect is because it said it runs down to the ischial tuberosity, when in fact, it runs down to the region of the ischial spine. So yes, this is the ureter. So kidney, bladder, let's trace it. The ureter runs down, goes down to the lateral wall of the pelvis, and then it enters in the region of the ischial spine to turn forward and enter the bladder. So this is a clearer photo. So we can see that as it crosses the common iliac artery, it enters the pelvis at the bifurcation of the common iliac artery into your external and internal iliac artery, goes down the lateral wall, and you can see that at the area of the ischial spine, not tuberosity, it turns forward and enters the lateral angle of your urinary bladder. So all of the following choices are correct except for letter B. Okay. Next question. The following statements concerning the bronchopulmonary segments are correct except which? A, it is a subdivision of a lung lobe. B, it is pyramidal in shape with its apex towards the lung surface. C, it is surrounded by connective tissue. D, it has a segmental bronchus, a segmental artery, lymph vessels, and autonomic nerves. E, when diseased, it can be removed surgically as a structural unit. Our correct answer here is letter B. So again, the question is asking all are correct except. So during the actual board exam, a lot of questions will come up where they are looking for the incorrect answer. So make sure to underline and encircle words like except or incorrect so you don't get confused. So let's talk about your bronchopulmonary segments. Now, the reason choice B is incorrect is because even though it is pyramidal shape, the bronchopulmonary segments, the apex do not point towards the surface of the lung. Instead, it points towards the lung root. So if you can look at this photo here, you can see it is pyramidal shape. This is the apex. Let me get my laser pointer. All right, so this is the apex and this is the base. And we can see that the base projects peripherally onto the lung surface. So again, base onto the lung surface, whereas the apex of this pyramid, apex, points towards the root of the lung. So what is a bronchopulmonary segment? So it is the smallest functionally independent region of a lung. So if this is your bronchopulmonary segment, it is complete with everything. It does have a tertiary bronchus. It has a segmental branch of your bronchial artery. It also has a segmental branch of your pulmonary artery, as well as pulmonary veins. So if you block one segmental bronchus supplying a bronchopulmonary segment, you would get a segmental atelectasis. So only one part of the lung or one bronchopulmonary segment would collapse. So because it is covered by connective tissue and it has its own blood supply, venous supply, lymph supply, as well as a bronchial supply, you can isolate and remove it without affecting adjacent regions. So whenever there is lung cancer isolated in one bronchopulmonary segment, or if there is an infection resulting in a collection of pus or an abscess, it usually localizes in a bronchopulmonary segment and you can remove it without affecting the adjacent regions. So remember that the right lung has 10 bronchopulmonary segments and the left lung has 8 to 9. So the reason it has 8 to 9 is because some of its segments tend to fuse, particularly the apical and posterior lobe tend to fuse in the left lung, resulting in an apico-posterior segment, and the anterior and medial basal bronchopulmonary segment of the inferior lobe of the left lung also tend to fuse, which is why you get an anteromedial bronchopulmonary segment versus in the right lung where they don't tend to fuse, so you get all 10 segments. Okay. Next, Which of the following pairs of organs includes purely endocrine glands? Is it the parathyroid and adrenal glands, pancreas and parathyroid gland, the thymus and the testes, or the adrenal and your ovaries? The answer here is letter A. So the question is asking which one is purely endocrine, meaning it has no other function other than to be an endocrine organ or an endocrine gland. So your parathyroid is a purely endocrine gland. Its only purpose is to secrete parathyroid hormone in response to changes in your calcium homeostasis. Your adrenal glands, made up of the cortex and the medulla, are also just endocrine glands. So the adrenal cortex secretes your corticoids. So it secretes your glucocorticoids, your mineralocorticoids, and your sex hormones. Your adrenal medulla secretes your catecholamines, your adrenaline or epinephrine, and your noradrenaline or norepinephrine. Remember, the definition of an endocrine gland is it releases hormones into the vascular component for uptake and distribution throughout the body. There is no secretory ducts because it just releases it into the bloodstream. So unlike your exocrine glands, they do not contain secretory ducts. So you can already rule out several of the options. Anything containing the pancreas should be ruled out because we know it has an exocrine function. So it is a heterocrine gland because yes, it does secrete hormones like insulin and glucagon in response to changes in your glucose homeostasis. But it also releases your digestive enzymes via the pancreatic duct, and that is an exocrine function. Your thymus is endocrine in that it secretes the thymosin. However, it also has a lymphatic function. So remember, this is where your T cells or where your T lymphocytes go to differentiate and to mature. Your testes and ovaries do produce sex hormones, estrogen, progesterone, and testosterone. However, they are also gonads. So they produce your gametes, your sperms, and your eggs. So they are not purely endocrine. So the organs that Junqueira, your histology textbook, categorizes as endocrine glands. So we have your pituitary glands, particularly the anterior pituitary gland, your pancreatic islets, so not the entire pancreas as an organ, just the islet cells, which secrete the insulin and glucagon, your adrenal cortex and medulla, thyroid and parathyroid, and your pineal gland, which secretes melatonin in response to your circadian rhythm. Next question. Fracture of the medial epicondyle with associated nerve injury will likely present with A, weak finger abduction and adduction, B, loss of wrist extension, C, inability to abduct the thumb, or D, loss of sensation over the first web space. So this is a two-step question. Fracture of the medial epicondyle, what nerve injury will it cause? It will cause an ulnar nerve injury. And therefore, what is the function of your ulnar nerve? Remember, it is responsible for finger abduction and finger adduction. So the answer is letter A. So recall that in medial epicondyle fractures, the closest nerve, or due to its proximity, it usually affects your ulnar nerve. So your funny bone is actually your ulnar nerve here at the medial epicondyle. So remember, the ulnar nerve passes from the arm into the forearm. It loops around the posterior edge of the medial epicondyle so that it can go into the forearm and enter your hand. So what is the function of the ulnar nerve? Remember that it innervates most of the intrinsic hand muscles, including your interosseous muscles, which are responsible for abduction and adduction of your fingers. I say most because there are exceptions, which we will discuss. So remember, it innervates most of the intrinsic muscles of the hand, and don't forget the mnemonic pad dab. So your palmar interosseous muscles adduct the fingers, and your dorsal interosseous muscles abduct the fingers. So these are your interosseous muscles. They are innervated by your ulnar nerve, and they can either abduct kung dorsal or adduct kung palmar. Pad dab. Don't forget. Now, I said except because there are some muscles of the hand, intrinsic muscles of the hand, that are innervated by your median nerve, specifically your thenar muscles and the lateral two lumbricals. So choice C said that you would have inability to abduct the thumb. So that is a function not of your ulnar nerve, but of your median nerve. Bakit median nerve? So your thenar muscles, so the muscles under the thumb here, remember OAF or OF, you have your opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. So the abductor pollicis brevis is responsible for abduction of the thumb, and that is not a function of your ulnar nerve, rather it is a function of the median nerve. So in addition to the thinner muscles, the median nerve also innervates the lateral 2 lumbricals. So remember, the mnemonic for lumbricals is make an upside down letter L with your hand. So that's the function of the lumbricals. It flexes at the MCP and extends at the interphalangeal joint. So this is the function of your lumbricals. The lateral 2 are innervated by the median nerve, and the medial 2 are innervated by the ulnar nerve. Lastly, choice B and choice D. So choice B was loss of wrist extension. Remember, buzzword, whenever it comes to the wrist and the fingers, whenever it says extension, automatically think of your radial nerve. And loss of sensation over the first web space, which is this area over here. Remember that this is innervated by your radial nerve, particularly the superficial branch of your radial nerve, which is the only part of the radial nerve that enters the hand. So as a quick anatomical reminder, remember that the radial nerve goes through the anatomical snuff box, and it is the superficial branch of the radial nerve that innervates the skin here, so over the lateral palm and lateral 3.5 digits up to the distal interphalangeal joint. Okay, so the median nerve innervates most of the medial side of the palmar side of your hand. Pero itong lateral side na to is your radial nerve. Next, true about the sex differences of the pelvis. A, the pelvic cavity is roomier in males than in females, and the distance between the inlet and the outlet is much shorter in males or in females. B, the false pelvis is shallow in females and deep in males. C, the sacrum is shorter, wider, and flatter in males than in females. Or D, the suprapubic angle or the pubic arch is more rounded and wider in males than in females. So the answer here is letter B. So the false pelvis is shallow in females and deep in males. The rest are incorrect. So the pelvic cavity is roomier in females, not in males. The sacrum is shorter, wider, and flatter in females, not in males. And the suprapubic angle or the pubic arch is more rounded in females as well. So remember that the false pelvis, how do we differentiate what is the false and the true pelvis? We draw an imaginary line on the medial surface of your pelvic bone. This is your pelvic brim. And remember that there's an anterior tilt to the pelvis. So if you look at the figure on the left, itong line na to, anything above it here is a false or the greater pelvis, and it's part of your abdominal cavity. Anything below it is your true pelvis or your lesser pelvis, and this is part of the pelvic cavity. And there are, of course, key differences in male and female pelvises. One of the reasons being males tend to have a heavier build, and so the pelvis is built to accommodate that. And I guess more importantly or more intuitively, biological females have to have a pelvis adaptation for childbearing or childbirth. So it would make sense why the female pelvis is shaped or is structured this way. So the false pelvis is shallow in females, but deep in males, because the false pelvis, we don't really need that for childbirth. We need the true pelvis to be wide and roomy. So the pelvic inlet, which is this drawing over here, it is oval in females and heart-shaped in males. It's oval in females because remember, it has to fit the head of the baby as it goes through childbirth. The pelvic cavity has to be wide in females, again, to accommodate childbirth, and the pelvic outlet has to be large. The sacrum, if you can see here, has to be wider, shorter, and flatter because it has to accommodate the fetal head as it goes through the cardinal motions of childbirth. It is also, the pubic arch is also rounder and wider in females, and the ischial spines are everted because we want more space in the pelvic cavity for the fetus to be expelled. So again, just think of what would make it easier for the female pelvis to accommodate a baby to exit, and that would be the answer for the female pelvis, and the exact opposite would be the male pelvis. So again, pelvic inlet is oval, pelvic cavity is very wide and roomy, pelvic outlet is large in females, the sacrum is short, it's wide, it's flat, and it's less curved to accommodate the fetal head. The pubic arch is rounder and wider so that it can be stretched and accommodate childbirth, and the ischial spines are everted, again, to make more room for the baby. And the exact opposite is true for the male pelvis. Therefore, the answer here was letter B. Next, branches of the hepatic artery except A, the cystic artery, B, the gastroduodenal artery, C, the left gastric artery, D, the right hepatic artery, or E, the left hepatic artery. So our answer here is letter C, the left gastric artery. So by elimination, we know for sure the right hepatic artery, the left hepatic artery, and the cystic artery are definitely branches of the hepatic artery. And we have to remember that the left gastric artery is incorrect because it is a branch of your celiac trunk or your celiac artery. It is one of the 3 direct branches of the celiac trunk. So laging natatanong yung anterior visceral branches. So remember that your entire gastrointestinal tract is divided into the foregut, the midgut, and the hindgut. Everything that is in the foregut is supplied by the celiac trunk. Everything in the midgut is supplied by branches of your superior mesenteric artery, and everything in your hindgut is supplied by branches of your inferior mesenteric artery. So, laging natatanong ano yung branches ng celiac trunk. So, the 3 first branches that you need to remember of the celiac trunk are 1, the left gastric artery, the splenic artery, and the common hepatic artery. So, even if you don't memorize this, if you would just remember na hepatic artery, your liver is on the right side of your body, your gastric is on the left side of your body, and left gastric artery. So it makes sense na hindi magiging branch ng left gastric artery or hindi branch ang left gastric artery ng hepatic artery because the hepatic artery goes to the right. So again, celiac trunk, 3 main branches, left gastric, splenic, and common hepatic. So common hepatic, trace natin ulit. It gives off a gastroduodenal artery, which gives off a right gastroepiploic artery and a superior pancreaticoduodenal artery. Important yung superior kasi the inferior pancreaticoduodenal artery is given by your superior mesenteric artery. So from common hepatic artery, magiging proper hepatic artery, it gives off the right gastric artery. And syempre, from proper hepatic, magba-branch off into your right and your left hepatic artery, as well as your cystic artery, which supplies your gallbladder. So again, another view of it here, orient natin yung sarili natin. Syempre, this is the right side of the body. This is the left side of the body because we have the spleen here. This is your aorta. You have your celiac trunk. 3 main branches ulit, left gastric, splenic, going towards the spleen, and of course, your common hepatic artery, which becomes the proper hepatic artery. Orient ulit natin sarili natin. This is the proper hepatic artery, branches into the left hepatic artery, the right hepatic artery, and the cystic artery over here. Okay, so the left gastric artery is definitely not a branch of your hepatic artery. Next question, which of the following nerves is derived from the posterior cord of the brachial plexus? Is it A, the long thoracic nerve, B, the axillary nerve, C, the nerve to the subclavius, D, the musculocutaneous nerve, or E, the ulnar nerve? Our answer here is letter B, the axillary nerve. Okay, so remember, posterior cord of the brachial plexus ang tinatanong. So si choice A or your long thoracic nerve is a branch of the roots of the brachial plexus. Si choice C, which is your nerve to the subclavius, is a branch of the upper trunk, whereas si musculocutaneous nerve is a lateral cord branch, and si ulnar nerve is a medial cord branch. So don't forget your brachial plexus. Remember to drink cold beer, RTDCB. You have the roots, which are made up of your C5, C6, C7, C8, and T1 nerves. They have 2 main branches, your dorsal scapular nerve and your long thoracic nerve. They then divide into your upper, middle, and your lower trunks. The upper trunk gives off 2 branches or 2 important branches, the nerve to the subclavius and the suprascapular nerve. They then go on to form divisions and eventually your cords, which become your terminal branches. So your cords are your lateral, your posterior, and your medial cords. So yung tanong is which is a branch of the posterior cord, and the answer was your axillary nerve. So just remember the mnemonic MARMU. So lateral, posterior, medial, MARMU. M, musculocutaneous nerve, is a lateral cord branch. AR, your axillary and your radial nerve, are posterior cord branches. And MU, your medial root of the median nerve, and your ulnar nerve are medial cord branches. So MARMU for lateral, posterior, and medial cord branches. Next question. A 5-year-old boy is noted to have severe pain, swelling, and redness around his right eye. He was diagnosed to have periorbital cellulitis. Which of the following routes describes the probable avenue of spread of the infection to the brain? Is it A, through the cribriform plate into the meningeal space, B, the facial vein to the ophthalmic vein to the cavernous sinus into the dura space, C, the frontal sinus into the sagittal sinus and into the subarachnoid space, or D, is it the facial canal through the internal auditory meatus to the posterior cranial fossa? Our answer here is letter B. So facial vein to ophthalmic vein. So what does this patient have? The patient has periorbital cellulitis. So it's cellulitis around the region of the eye. And we have to figure out how it manages to get intracranially. So remember the pathology cavernous sinus thrombosis. It results from infections in the orbit, the nasal sinuses, and superior part of the face. The reason it can reach the cavernous sinus is because facial veins make very important connections through your superior and inferior ophthalmic veins. So whenever you have bacterial infections of the skin of your face, commonly by staph, either in the nose, the sinuses, or the teeth, they can spread to your cavernous sinus. So look at this figure on the right. You have your supraorbital vein and your angular vein, which are facial veins. The supraorbital vein can drain into the superior ophthalmic vein. The angular vein can drain into the inferior ophthalmic vein, and they both eventually drain into the cavernous sinus. So because the ophthalmic veins communicate with the cavernous sinus, they act as a route by which infections can spread from outside to inside the cranial cavity. So a quick refresher on the cavernous sinus. Remember that it is paired on either side of the sella turcica, which houses your pituitary gland. They receive blood from cerebral veins, from ophthalmic veins, and from emissary veins. What do they contain inside them? So they contain the ICA, or the internal carotid artery, and your 3, 4, V1, V2, and 6 cranial nerves. So your oculomotor nerve, your trochlear nerve, your V1 and V2, so ophthalmic and maxillary division of your trigeminal nerve, and your abducens nerve. Ang natatanong din, which ones aren't lateral? So as we can see, 3, 4, V1, and V2 cranial nerves are lateral, whereas the abducens nerve and C, internal carotid artery, are medially located within the cavernous sinus. Next question. Placing your finger in the epiploic foramen of Winslow, the structures immediately palpated superiorly and inferiorly are A, the caudate lobe of the liver and the duodenum, B, the portal vein and the inferior vena cava, C, hepatoduodenal ligament and caudate lobe of the liver, D, gastroduodenal artery and common bile duct. So the answer here is letter A. So the caudate lobe of the liver is superior and the duodenum is inferior. Si portal vein, that is anterior. Si IVC is posterior. Hepatoduodenal ligament is again anterior, and caudate lobe of the liver is superior. Gastroduodenal artery and the common bile duct. So si bile duct is located anteriorly, pero hindi related si gastroduodenal artery to your foramen of Winslow. So the answer is definitely letter A. So to really understand the foramen of Winslow and its relation to the other structures, we have to review the subdivisions of the peritoneal cavity. So ano nga ba yung greater sac and lesser sac? Ano yung foramen of Winslow? What is it connecting? So remember that you have the greater omentum and the lesser omentum. Okay, so the greater omentum over here is a peritoneal fold that hangs down like an apron. So it connects to the greater curvature of the stomach and the duodenum. It goes down like an apron and attaches back up to the transverse colon. So the space between this greater omentum and the abdominal wall, so itong everything in cyan blue, that is your greater sac. The lesser omentum naman connects the lesser curvature of the stomach with the duodenum and the liver, and it ends in a free edge called the hepatoduodenal ligament. So anything behind that, this yellow space over here, is the lesser sac. So if we look to the right, we're looking at a cross section. So ito yung right ng patient kasi ito yung liver, ito yung left kasi ito yung spleen. We can see that this yellow space, the lesser sac, okay, is what's behind the lesser omentum. And this lesser omentum has a free edge, which is the hepatoduodenal ligament containing the portal triad. And as you can see, there is a connection between the cyan blue and the yellow, itong small hole na ito. That hole is the epiploic or Winslow foramen. So again, that is your epiploic or your omental Winslow foramen, okay? So again, it is the opening from the greater sac outside into the lesser sac inside through this tiny hole, and it is immediately posterior to the hepatoduodenal ligament. So really important to understand the relation of the epiploic foramen with the rest of the organs of the body or the rest of the viscera. Again, superiorly caudate process of the liver, anteriorly the free edge of your lesser omentum, which is the hepatoduodenal ligament containing your portal vein, hepatic artery, and your bile duct. Inferiorly, the first part of the duodenum, and posteriorly, the inferior vena cava. So again, superior caudate lobe of the liver. Anterior to this hole is this hepatoduodenal ligament. Inferior, hindi kita, but that's the first part of the duodenum. And of course, behind it is the inferior vena cava. So what is the surgical relevance of this anatomy? So remember that the cystic artery supplies blood to the gallbladder. So when you are doing a cholecystectomy, you do have to ligate the cystic artery. And you also, of course, have to stop profuse bleeding from the cystic artery. So if you ligate or if you accidentally cut the cystic artery without proper hemostasis, you could have hemorrhage from the cystic artery, and you need to quickly stop the bleeding. The way to do that is to press down firmly, enter the index finger into the omental foramen, and the thumb will clamp down over it, because this will then press on the hepatoduodenal ligament containing the hepatic artery. And remember, the hepatic artery is what feeds the cystic artery. So by doing this maneuver, which is called the Pringle maneuver, you can temporarily control the bleeding when you accidentally ligate the cystic artery without being ready for hemostasis. Okay, next question. A 59-year-old male suffered an ischemic stroke obstructing the anterior cerebral artery. Which of the following physical findings will be expected during examination? Is it A, contralateral upper extremity weakness, B, contralateral lower extremity weakness, C, ipsilateral upper extremity weakness, or D, ipsilateral lower extremity weakness? Our answer here is letter B, contralateral lower extremity weakness. So letter A, or choice A, is what we would find if there was an obstruction of the middle cerebral artery. So you would get contralateral upper extremity weakness. Choice B is, of course, your ACA. And choice C and D, you can automatically exclude that from your options, because remember, whenever it comes to cerebral infarcts and weakness, most often, or 99% of the time, it occurs with contralateral weakness due to decussation of your nerve fibers. When it does present ipsilaterally, when you have neurological findings ipsilateral to the lesion, you have to think of your cerebellar findings, but not your middle or anterior cerebral artery findings. So it's really important to remember the homunculus. So let's orient ourselves. This is the central sulcus, or the fissure of Rolando. Anterior to the central sulcus is your somatomotor cortex, or your primary motor cortex. And posterior to that is your primary sensory cortex. So remember, the homunculus shows us that for both sensory and motor functions, you have to imagine a human na nakahiga, tapos andito yung ulo niya, and the legs are dangling in the medial end. So if we compare it to the vascular territory of your cerebral arteries, you will see that the anterior cerebral artery supplies the medial part of the primary motor and primary sensory cortex. So if you compare that to the homunculus, ano yung nasa medial end, it's your lower extremities. Your middle cerebral artery supplies the lateral portions, which is why it would affect the upper limbs, the face, the temporal lobe, and the frontal lobe. Your posterior cerebral artery naman would supply your occipital lobe, which is why the findings would usually be visual symptoms like contralateral hemianopia with macular sparing. So when it comes to contralateral paralysis or sensory loss of the lower limb, think of your anterior cerebral artery over here, and never forget your homunculus. So again, anterior cerebral artery, itong region na ito, and middle cerebral artery, itong region na ito. Next, muscle that originates from the superior ramus of the pubis and inserts at the upper end of the linea aspera. Is it your sartorius, your iliacus, your psoas, your pectineus, or your rectus femoris? So this is quite difficult to answer. Basta origin and insertion, and you have to imagine what the muscle looks like and where it is in the body. So the answer here is letter D, your pectineus. So let's review these muscles. So nakastar yung laging natatanong. So let's start with the sartorius, or the longest muscle in the body. So remember, it crosses and therefore acts across two joints. So it originates in the anterior superior iliac spine. So ito yung sartorius, goes down, goes medially, and inserts into the upper medial surface of the shaft of the tibia. So what supplies this muscle? This is the femoral nerve. And what are its actions? So Faber and Thayer. So Faber, it abducts and externally rotates the hip. And Thayer, it internally rotates the knee. So a way to remember it is, if you want to sit down cross-legged, so you take the Indian sitting position. So diba, you would imagine yourself sitting down like that. That's what the sartorius does. It abducts and externally rotates your hip while internally rotating your knee. So imagine yourself sitting cross-legged on the floor. That is the function or the action of your sartorius muscle. Then we have your iliopsoas, which are actually two separate muscles, your iliacus and your psoas. So the iliacus originates in the iliac fossa, while your psoas major originates on the transverse processes, bodies, and intervertebral discs of your T12 up to your L5 vertebra. But they both travel downwards and go in between the space between the ingual ligament and the pelvic bone, so they can both insert in the lesser trochanter of your femur. So when they go down and insert together, they no longer are two separate muscles. You then call them the iliopsoas. Okay, and they both have the same function. They are very strong hip flexors. However, their innervation is different. So the psoas major, it makes sense kasi katabing-katabi niya yung lumbar vertebral bodies. It is innervated by the lumbar plexus. Si iliacus is innervated by the femoral nerve, but they both assist in hip flexion. Lastly, your pectineus, this short, broad muscle over here, it originates in the superior ramus of the pubis, inserts into the upper end of the linea aspera, which is just a line on the posterior surface of the femur. And it is also innervated by your femoral nerve, and its action is to fad or adduct. So fad, pectineus, fad, adducts the hip. Sartorius, Faber, and Fur, it abducts and externally rotates the hip while internally rotating the knee. So remember yung sartorius, imagine yourself going from a standing position to sitting cross-legged on the floor. That function or that movement of your hip and your knee to do that is done by the sartorius. Next, the jejunum and the ilium can be differentiated on the basis of the following anatomic features, except which? Is it A, there are numerous 4 to 5 arterial arcades associated with the jejunum? B, the plicae circularis are much more prominent in the jejunum than in the ilium? C, fat depositions are generally present throughout the mesentery associated with the ilium? D, the jejunum is generally located in the upper left region of the abdominal cavity? E, the Peyer's patches are characteristic of the lower ilium and may be visible on the surface. So the question is except. Your answer here is letter A. So the rest of the options are correct. The numerous arcades are not associated with the jejunum. They are associated with the ilium. So remember, key differences between the jejunum and the ilium, starting with the location. So proximal 2/5 of the small intestines, mostly in the left upper quadrant. So that means that choice D is correct, where it was asking about the location. Si ilium, because it is the distal 3/5, it is mostly in the right lower quadrant. In terms of the walls, your jejunum is much larger in diameter and thicker, whereas your ilium is thinner. In terms of your arterial arcades, so you can see here, these are the arterial arcades, etong loops na ito. So this one is your jejunum and this one is your ilium. So you can see the jejunum has much less prominent arterial arcades. They are very small and quite few. And they have translucent areas called windows between the blood vessels of the mesentery, versus your ilium, which has large, several, and numerous arterial arcades or loops. So dahil maliit lang yung arterial arcades ng jejunum, it makes sense na yung vasa recta, itong straight arteries, are longer in the jejunum. Tapos dahil madami ng space ang na-occupy ng arterial arcades, the vasa recta in your ileum are much shorter. So the fat is also scantier in the jejunum and more prominent in the ileum. So you can see much more fat here in the ileum. Peyer's patches are absent in the jejunum but present in the ileum. So ito yung Peyer's patches natin, or aggregated lymphoid nodules. And your plicae circularis, or your circular folds, are larger, taller, more numerous, and much more closely packed in the jejunum. Etong corrugated interior that you can see here. Versus in the ileum, where sometimes they are short and widely separated or completely absent in the lower part of the ileum. So a way to remember it is you mustn't forget the L's of the ileum. So the ileum has more lipids, more fat. It has more loops, so it has more arterial arcades, and it also has more lymph in the form of your Peyer's patches. Okay, next question. The following structures could be eroded as a result of perforation of an ulcer in the posterior stomach or in the posterior wall of the stomach, except which? The splenic artery, the right kidney, the pancreas, the left kidney, or the spleen. So it's asking if nagka-perforation ka sa posterior wall ng stomach and naglabas yung acidic contents, which organ would not be affected? So that is letter B, the right kidney. So you have to visualize asan ba yung stomach and what's behind it. So choice B is incorrect because it's not the right kidney that would be affected, it's the left kidney. So posterior to your stomach is the stomach bed on which the stomach rests when a person is in the supine position and is formed by several structures forming the posterior wall of the omental bursa. So this is your lesser sac, your pancreas, your transverse mesocolon, transverse colon, left kidney, and the adrenal gland, and the spleen or the splenic artery, which is much more visible here. So imagine, ito yung stomach natin. Tanggalin natin siya so we can see what's posterior to it. Obviously, the splenic artery and the spleen would be posterior to the stomach kasi if you remember the anatomy, alam mo nasa likod siya. Si pancreas is also definitely behind it. You also have the transverse colon over here and the left kidney and the left suprarenal gland. So if we look at the cross section, so this is a superior view. We're looking downwards. If hinati natin yung body, ito yung stomach on the left side. Ito yung right kidney, malayo sa stomach. If you had an ulcer over here, hindi ma-affect ang right kidney, but you would affect the pancreas, as you can see here. You would affect the left kidney, the splenic artery, and the spleen. Okay. Next. Which of the following is true about the cells of the lungs? A, the main role of type 2 pneumocyte is to provide a barrier of minimal thickness that is readily permeable to gases. B, type 1 pneumocyte contains lamellar bodies. C, Clara cells are able to divide, differentiate, and repair other damaged cells. D, type 1 pneumocytes are large rounded cells that secrete a surface active material. So yung tamang sagot natin dito ay letter C. Clara cells or club cells are able to divide, differentiate, and replace other damaged cell types. Si choice A describes a type 1 pneumocyte, which is yung a barrier of minimal thickness that is readily permeable to gases, whereas choice B and choice D describe your type 2 pneumocytes, not your type 1. So quick refresher on your Clara cells or your club cells. So club cells na yung current name niya. Previously, it was named after Dr. Max Clara. So they are non-ciliated cuboidal or low columnar cells in the epithelium, mostly in the distal part of the respiratory bronchiole. So you won't really see them in your alveoli. So they have three main functions: surfactant, stem cells, and detoxification. So they secrete components of surfactant. They secrete the necessary sphingolipids. They are stem cells, meaning they can differentiate and or regenerate into cells that are needed to replace damaged cells. And they also detoxify noxious substances. So compare this to your type 1 and your type 2 pneumocytes, which you would find in the cells of your alveoli. So si type 1, number 1, think about it as covering 97% or the majority of the alveolar surface. And ano nga ba yung function ng lungs or ng alveoli? The number 1 function is for gas exchange. So for gas exchange to be efficiently done, type 1 alveolar cells have to be very thin. Compare that to the type 2 alveolar cells, which would contain about 3 to 5%, which would cover about 3 to 5% of the alveolar surface. So kung yung type 1, very thin, responsible for gas exchange. Yung type 2 naman ay cuboidal and bulging, and quite similar to the Clara cells, they also have a stem cell function. They divide to replace their own population after injury, and they can also replace type 1 alveolar cells after injury. They contain lamellar bodies, and the main role of these lamellar bodies is to secrete the necessary precursors for your pulmonary surfactant. So itong lamellar bodies ang marker mo for type 1 cells. So if you look at it under a microscope, itong napakanipis na squished cell is your type 1 pneumocyte, and itong thicker cells, thicker and cuboidal, which contains the lamellar bodies, yan yung type 2 pneumocyte mo. Next, which of the following is true regarding the thyroid and the parathyroid glands? A, the parathyroid glands are brownish red tiny ovoid bodies attached to the posterior surface of the thyroid gland. B, the thyroid and inferior parathyroid glands originate from the third pharyngeal pouch. C, the thyroid and parathyroid glands share the same blood supply and lymphatic drainage. Or D, all of the choices are correct. Our answer here is letter C. So si letter A, pampalito, it's not red. It's usually a yellow, tiny ovoid body attached to the posterior surface of the thyroid gland. Itong originating from the third pharyngeal pouch, that is incorrect, and I'll explain why later and show you a figure. Itong share the same blood supply and lymphatic drainage, that is correct. So let's go through the thyroid gland and your parathyroid glands. So your thyroid gland is one butterfly-shaped gland. So ito, posterior view ito, okay? So to orient ourselves, itong green, naka-highlight in green is your thyroid gland. And itong small yellow ovoid bodies, paired sila, 2 pairs, are your superior and your inferior parathyroid glands respectively. Location. So your thyroid gland, of course, lies in front of the trachea, itong butterfly shape that we can see here. And your parathyroid glands, ito naman posterior view ulit, are on the posterior surface of your thyroid gland. So itong yellow, small ovoid bodies. In terms of the cells, your thyroid glands contains follicular cells and parafollicular cells, or your thyrocytes and C cells. Your follicular cells secrete T3 and T4, the active thyroid hormones, and your C cells secrete calcitonin, which function to reduce the amount of serum calcium. Your PTH contain your principal or chief cells, which of course secretes your parathyroid hormone, and they also have an oxyphil cell whose function is not fully known yet. Now, itong embryologic origin, the reason why one of the options was incorrect is because the thyroid is derived from the thyroid primordium. So the thyroid primordium descends, it actually starts sort of in the roof of the tongue and then descends through the thyroglossal duct until it attaches to the anterior portion of the trachea, and then the thyroglossal duct is meant to close in adulthood. So if it stays patent, you have a patent thyroglossal duct cyst in children. Yung parathyroid glands naman are from the third and the fourth pharyngeal pouch. And wag malito, the third pharyngeal pouch actually makes the inferior parathyroids, and the fourth pharyngeal pouch makes your superior parathyroids. In terms of arterial supply, magkapareho lang sila. They have blood supply from the superior and inferior thyroid artery. Yung thyroid glands, sometimes it gets blood supply from a thyroidea-ema artery, which is present in only less than 10% of the population. In terms of venous drainage, magkapareho lang din. They get the superior, middle, and inferior thyroid veins. And the lymphatic drainage is also quite similar. So they all drain into the deep cervical and the paratracheal lymph nodes. In terms of innervation naman, the innervation of the thyroid gland is from the superior, middle, and inferior cervical sympathetic ganglia, si parathyroid superior or middle lang. But venous drainage, arterial supply, and lymphatic drainage is pretty much the same for both the thyroid and the parathyroid gland. Next, cells in the peripheral blood larger than RBCs with kidney-shaped nucleus and frosted glass cytoplasm. So frosted glass cytoplasm is a buzzword for our letter D, our monocytes. So remember the key features of your different blood cells. Erythrocytes are anucleated, so meron silang central pallor and biconcave. Your platelets are very small. They are, in fact, the smallest formed element in the blood and do not contain any nucleus as well. Your plasma cells, ano yung buzzword mo dyan? It's your clock face or spoked nucleus. Clock face nucleus or spoked nucleus, okay? Itong basophil, you have a bilobate nucleus covered by densely staining purple or basophilic granules. Eosinophil also bilobate. However, the eosinophilic granules are usually pinkish in color and they do not cover the nucleus versus a basophil na covered ang nucleus. Yung neutrophil nyo have multi-lobed nucleus, which is why they're sometimes called your PMNs or your polymorphonuclear cells with large spherical azurophilic granules. Monocyte nyo, again, they are larger than the red blood cell and they have a kidney-shaped nucleus with a frosted glass cytoplasm. So wala sila nung prominent granules that you see in the basophils, eosinophils, or neutrophils. Your lymphocyte naman has a very large circular nucleus and very small amounts of surrounding cytoplasm. So ano ulit yung buzzwords natin? Ito, covered ang nucleus, eosinophil, not covered ang nucleus, neutrophil, multi-lobed nucleus, monocyte, kidney-shaped nucleus with a frosted glass cytoplasm, and lymphocyte, very, very large nucleus with scanty amount of pale cytoplasm. Next question, which of the following is not part of the Papez circuit? Is it A, the hippocampus, B, mammillary bodies, C, posterior thalamic nuclei, D, cingulate gyrus, or E, your parahippocampal gyrus? The answer here is letter C, posterior thalamic nuclei. It is incorrect kasi dapat anterior thalamic nuclei, whereas the rest of the choices are members of the Papez circuit. So ano nga ba yung Papez circuit? It is the circuit that ties together the cerebral cortex and the hypothalamus. So it provides a substrate for the convergence of cognitive or cortical activities, emotions, and expression. So remember that the hippocampus plays a major role in memory and consolidation of memories. It receives a lot of the memories via the entorhinal cortex, and then it connects with other structures in the brain via the circuit called the Papez circuit. So the main function of the Papez circuit is to support this emotional and mental synthesis and regulation. So let's trace the Papez circuit. It starts with the hippocampus over here. It goes up into the fornix, and then it enters the mammillary body over here. From the mammillary body to the anterior thalamic nucleus, it goes through the mammillothalamic tract, anterior thalamic nucleus. It then goes into the cingulate gyrus, down the entorhinal cortex, and enters the hippocampus again. So hippocampus, fornix, mammillary bodies, mammillothalamic tract, anterior thalamic nucleus, cingulate gyrus, entorhinal cortex, and hippocampal formation. Again and again and again and again. So again, it is meant to support and regulate emotional expression and memory processes. So it plays a role in the formation, the retention, storage, and retrieval of episodic memories. Okay? Next, to improve the blood flow to the interventricular septum, a coronary bypass procedure is elected. During surgery, the anterior interventricular artery is located and prepared to receive a graft. The vessel lying adjacent to the anterior interventricular artery is A, the great cardiac vein, B, the middle cardiac vein, C, the anterior cardiac vein, or D, the small cardiac vein. Our answer here is letter A, the great cardiac vein. So if we can look at this figure over here, so this is an anterior surface or the anterior portion of the heart. So going down with the anterior interventricular artery is your great cardiac vein. So itong red, anterior interventricular artery, itong blue, your great cardiac vein. So we have to remember which artery corresponds to which vein. So according to your BRS anatomy, which was the reference for some of the previous questions, kapag lumalabas itong coronary arteries and accompanying veins, you can remember it by AMP GSM blue. GSM blue kasi GSM yung vein, blue vein. So G, great cardiac vein, S, small cardiac vein, M, middle cardiac vein corresponds to the A, anterior interventricular artery. Small cardiac vein corresponds to the right marginal artery, and middle cardiac vein corresponds to the posterior interventricular artery. So some references will also say that the small cardiac vein accompanies the right coronary artery, but according to BRS anatomy, it's the right marginal artery, and yun din yung lumabas sa previous exams. So as we can see here, posterior interventricular artery, so P dun sa AMP GSM natin is accompanied by your M, middle cardiac vein. Anterior interventricular artery is accompanied by the great cardiac vein. And the small cardiac vein accompanies the right marginal artery, although in this figure, it shows the right coronary artery. Pero according to your BRS, again, small cardiac vein accompanies the right marginal artery. Next. Artery that supplies the thyroid gland that arises from the brachiocephalic artery or the arch of the aorta. Is it the superior thyroid artery, the inferior thyroid artery, the thyroidea-ema artery, accessory thyroid arteries, or both A and C? So the answer here is your letter C. So for blood supply of the thyroid gland, remember that it comes from two main arteries and one optional artery present in about less than 10% of the population. So the superior thyroid artery is a branch of your external carotid artery. Your inferior thyroid artery is a branch of the thyrocervical trunk. So as you can see here, inferior thyroid artery, branch of the thyrocervical trunk. Now, in less than 10% of the population, you do get a thyroidea-ema artery, which is a direct branch of either the brachiocephalic trunk or in some other patients, sometimes directly from the arch of the aorta. And it ascends in front of the trachea into the isthmus of your thyroid gland. So this is anatomically important because sometimes if you do a tracheostomy in somebody who does have the thyroidea-ema artery, you can sever this artery and cause quite significant bleeding. So again, external carotid artery, superior thyroid artery, thyrocervical trunk, inferior thyroid artery, brachiocephalic trunk or arch of the aorta, thyroidea-ema artery. Last question, which of the following pairs does not match? The external spermatic fascia from the external oblique aponeurosis, cremasteric fascia from your internal oblique aponeurosis, internal spermatic fascia from your internal oblique aponeurosis, deep inguinal ring, fascia transversalis, or superficial inguinal ring in your external oblique aponeurosis. So it's asking which pair of the lining of your spermatic cord is matched incorrectly to which layer of the abdominal wall. So the answer here is letter C. So internal spermatic fascia is not from the internal oblique aponeurosis. So let's review and see what the correct answer for letter C should be. So remember that in uterus, the testes is actually not in the scrotum. It is an intra-abdominal organ. It is located inside the abdomen. The processus vaginalis forms an invagination through the abdominal wall muscles all the way down to the gubernaculum until it enters the scrotum. And then when that processus vaginalis is formed, the testes descends and becomes an intrascrotal organ instead of an intra-abdominal organ. Habang pababa yung processus vaginalis, hinihila niya yung layers of the abdominal wall until it becomes layers of the spermatic cord. So if we can see here, kung ito yung testes, we have the parietal peritoneum, you have the transversalis fascia over here, internal oblique, and your external oblique muscle. Yung processus vaginalis, ihila niya pababa itong layers na ito until they cover the testes and the spermatic cord. So this is a better view. So sagittal view ito. So this is your transversalis fascia, internal oblique muscle, and external oblique muscle. Pahila pababa, naging layers na siya of your spermatic cord and your testes coverings. So the most important ones to remember are the ones in bold in this table. So it's the external oblique aponeurosis, which also becomes the superficial inguinal ring, is what will eventually become the external spermatic fascia. See, internal oblique muscle, so we're going from outside to in. The internal oblique muscle is what eventually becomes the cremasteric fascia. And the fascia transversalis, or the deep, which also becomes a deep inguinal ring, is what eventually becomes the internal spermatic fascia. So if we can look here again, so going outside in, the external oblique aponeurosis will eventually become the external spermatic fascia. The internal oblique muscle is what becomes the cremasteric fascia, and that fascia transversalis is what becomes the internal spermatic fascia. So the ones that you need to remember, the three most important ones, can be remembered by the mnemonic ICE, TIE. Okay, so going from inside to outside, your internal spermatic fascia comes from the transversalis fascia, your cremasteric fascia comes from the internal oblique aponeurosis, and your external spermatic fascia comes from the external oblique aponeurosis. So si letter C, mali siya kasi internal spermatic fascia, again, ICE-TIE. So ICE-TIE, internal spermatic fascia should come from the transversalis fascia. And your internal oblique aponeurosis does not become the internal spermatic fascia, but becomes the cremasteric fascia. So again, ICE-TIE. Yun lang yung pinaka-important ones to remember when you want to remember the precursors of the lining of the spermatic cord and you want to remember which layer of the abdominal wall siyang galing. Okay, so that's it for your anatomy and your histology.
Now, patapos na ang iyong day 1 of the first weekend of the PLE. So good job. Konting tiis na lang, guys. So let's head to micro and parasitology. Number 41. A 21-year-old leukemia patient was admitted for a 3-week history of fever, left facial pain, and edema. On examination, there was note of a bluish-black discoloration over her left eye and nose with accompanying purulent discharge. On the 6th hospital day, she was found to be stuporous and eventually went into arrest. Nasal samples were taken prior to the demise of the patient. What would be the most likely finding? So ang tanong dyan, ano kaya ang sakit ng ating pasyente? So we have here an immunocompromised patient having a head and neck lesion. So think dito kung ano yung mga posibleng mga fungal organisms na pwede mag-cause ng head and neck problem. And one of them definitely is your mucormycosis. As you can see, the options are all suggesting a fungal organism problem. Diba, you have your different terminologies. May septate, yeast cells, hyphae. So all in all, only rule in here a problem of the fungal organisms. So it's also testmanship. You look at the options, you look at the question before reading the whole case. Okay, before analyzing everything. So mukha siyang mucormycosis. An immunocompromised patient having a head and neck lesion. Now, in some cases, if hindi siya immunocompromised, the patient could be in diabetic ketoacidosis. It's still a strong risk factor for mucormycosis. And among the choices, mucormycosis is defined if ang agent ay merong non-septate hyphae with wide angle branches. Ang A natin na septated and having V-shaped branches, pag V-shaped kasi, it's an acute angle. Acute angle, aspergillus naman yan. Having oval yeast cells with a wide polysaccharide capsule, it is your Cryptococcus organism. Kung meron kang pseudohyphae and you have a blastoconidia formation, think about Candida organisms. So this is a case of what we call rhino-orbitocerebral mucormycosis. As mentioned, it is usually seen in immunocompromised states and also patients with diabetic ketoacidosis or those with uncontrolled DM. As you can see, in aspergillus, they have septations, may hati sa gitna. Ang ating mucor, it is aseptate or non-septated. Moreover, acute angle ang ating aspergillus. Acute angle A, aspergillus. In mucor naman, it is a wide angle branching. Okay? Pwede siyang obtuse, pwede siyang right angle. Basta wide ang kanyang branching. So that is their main difference. 42. Which characteristic of Entamoeba histolytica differentiates it from commensals such as Entamoeba coli? Now, kapag meron kang stool exam result, always check if meron bang trophozoites. And if these trophozoites contain RBCs, because that is pathognomonic for a pathogenic organism. And between the two, pathogenic po ang ating Entamoeba histolytica. Our Entamoeba coli is only a commensal. And if you have erythrophagocytosis, yan ang type ng trophozoite na binibigyan mo ng gamot. Okay? Kasi if absent ang ganyang feature, most likely baka cause yan ng baka ang cause ng diarrhea is baka ibang organism. Now, some pearls, E. hartmanni is smaller than E. histolytica. E. hartmanni is also a type of commensal, while Iadomoeba, Buchli, has no peripheral chromatin and has a large glycogen body. So it is also a form of commensal. 43. A biologic false positive test result with VDRL may be seen in which condition? It is seen in lupus. Okay. Remember guys, non-treponemal tests can be used as a test of cure. Okay? So ito yung mga RPR saka VDRL. Now, there are some cases kung saan pwede ka mag-false positive to VDRL. So think of this mnemonic guys. VDRL. Viruses, if you have infections of Epstein-Barr virus and hepatitis viruses, with the use of marijuana, representing drugs, if you have rheumatic fever and rheumatoid arthritis, and L is for lupus and leprosy. So take note of false positivity with VDRL. Number 44. Which feature correctly describes reoviruses? Reoviruses is very unique kasi they are the only medically important double-stranded RNA virus. So, recall guys, RNA virus have single-stranded RNA except your reoviruses. Replication of most RNA viruses happens in the cytoplasm, except for influenza and retroviruses, which may occur inside the nucleus. And take note kung saan dyan ang mga naked sa envelope. So para matandaan yan, take note of my own mnemonic. Healthcare providers are raw and naked. So ang mga naked na viruses, ang ating Hepevirus, Calisay virus, Picorna virus, and Reo virus. So these are your naked RNA viruses. 45. We have here a 1-year-old boy with rashes starting from the neck and trunk. He had fever 3 days prior to the appearance of rashes. Upon examination, there were erythematous papules on the soft palate and at the base of the uvula. The most likely causative agent of this patient's condition is... So muna, ano bang sakit to? So we have here rashes. Okay, so doon pa lang, rashes in the childhood population. So marami ka nang naiisip automatically. However, in this case, hindi sinabi yung nature ng ating rash. Hindi sinabi yung description niya. Ang sabi lang, neck pababa. Okay? Now, but another clue here is we have here an enanthem. Ang rash natin dito ay tinatawag na exanthem. It's found on the skin. But we also have here an enanthem. And ang ating enanthem here tells us that meron mga lesions sa ating soft palate and the base of the uvula. And those are known as Nagayama spots. These Nagayama spots are seen in Roseola infantum. Kapag meron kang lesion sa ating soft palate at sa base ng ating uvula. And these Nagayama spots are being caused by your human herpes virus 6. How about the other viruses? What are their enanthems? In rubella, we have your Forchheimer spots, only found in the soft palate. While rubeola, also known as measles infection, they have complex spots found at the buccal mucosa. Okay? So your human herpes virus 6 is actually known to cause high fever, and in children, they can also cause clinical seizures. So yun yung mga prominent dyan na features niya. High fever, a rash, and having clinical seizures. Those are the prominent features of Roseola infantum. Most of them usually have a benign course, and all humans, around 90%, may be infected by the age of 3. 46. A 29-year-old male, known IV drug user, sought consult kasi meron siyang high grade fever of 2 weeks. Upon PE, meron siyang grade 3 to 6 na murmur, heard over the left parasternal area. Now, nag-focus sa kanya, may nakitang tricuspid valve vegetations. Blood CS was done and shown to have gram-positive cocci. What is the most likely organism given in the case? So, let's first look at the risk factors of this patient. Meron siyang IV drug use. So, yan. You have an IV drug user. And ang kaya sintomas dito ay meron siyang murmur dito. A new onset murmur along with fever. And there were vegetations shown at the tricuspid valve. These satisfy a possibility for having an infective endocarditis. Okay, confirm pa siya na may tumubo na gram-positive cocci sa ating blood CS. So, kapag meron kang infective endocarditis, tapos ang iyong risk factor ay IV drug use, most commonly affected na valve ang ating tricuspid valve. It makes sense. Bakit? Kasi when meron kang IV drug use, di ba? Saan ka ba naglalagay ng drugs? Sa skin, dito. So dyan, ang nangyari, yung organisms na na-deliver sa ng ating IV drug ay maaaring dumaan sa ating IVC eventually or sa ating SVC. And from the vena cava, papasok yan sa ating right atrium, lodging to our tricuspid valve. The first valve encountered, okay, coming from the vena cava. And kapag nag-lodge na doon, maaari sila mag-cause ng infective endocarditis. Now, dahil ang ating IV drug use employs the use of intravenous mode of administration, maaaring may masama na bacteria na normal flora ng ating skin. So, think of Staph aureus in this case. And Staph aureus has a beta hemolytic pattern on blood agar. Thus, it is the best answer in this case. Always think of Staph aureus kapag meron ka mga IE drug users. And the most involved valve is the tricuspid valve. 47. A 52-year-old male known diabetic was admitted for a 1-week history of fever and cough. Ramsing was performed showing a gram-negative bacilli. And this bacilli was incubated at 42 degrees Celsius and was oxidase positive. So nakatubo siya at that very high temperature. Moreover, the isolate was noted to have a corn tortilla odor. What is the most likely organism? Now, in the risk factors here, isipin mo, okay, diabetic, meron siyang history of fever and cough. So we'll think of different organisms that can present such as pneumonia. Pero sinabi dito, gram-negative bacilli siya. Dahil gram-negative bacilli dyan, tanggal na yung iba ating mga organisms such as Streptococcus in this case. Kasi this is actually a gram-positive na coccus, di ba? Moreover, it is oxidase positive. So, if gram-negative bacilli ka, usually you belong to the family Enterobacteriaceae. And most of them are oxidase negative. Ang tanging organism na oxidase positive doon, among the most common ones, is your Pseudomonas aeruginosa. And this is backed up by the isolate having corn tortilla odor. So, all in all, B is the best answer here. Remember guys, these are the key features of the Pseudomonas aeruginosa infection. It is oxidase positive, unlike those that are oxidase negative in the Enterobacteriaceae family. They can grow up to 42 degrees Celsius and it produces a corn tortilla odor. 48. Which of the following Clostridial species has alpha toxin mediated lecithinase activity, demonstrating in egg yolk agar? Correct answer is Clostridium perfringens. Okay, ang toxins ng ating tetany is tetanus toxin, while botulinum naman is the botulinum toxin. In difficile, it is a problem usually occurring if meron kang antibiotic use. Ang nangyayari, nagbabago ang ating microflora leading to proliferation of your C. difficile, causing colitis, causing pseudomembrane formation. Okay, so in perfringens, we use that alpha toxin. They use that, and eventually they can lead to what we call necrotizing fasciitis. So these are features of your C. perfringens skin infection. 49. Which of the following factors account for the antigenic variation seen in Neisseria species? So specifically, I think this is pointing to a Neisseria gonorrhea species. And definitely, that species require the changing of its pili. Okay, nagbabago yung antigen niya para makatakas siya sa ating mga immune cells na ating system. Okay? So, virulence factors, IgA protease. Of course, it's found in your different Shin organisms. Found in Streptococcus pneumoniae, in your H. influenzae, and Neisseria organisms. Your Neisseria have LOS, okay? Only a lipo-oligosaccharide instead of the usual lipopolysaccharide. Now, specifically, gonococci have an OPA, okay? It leads to an opaque colony, and it is also a strong virulence factor. And the pili is the major factor involved in antigenic variation. Kaya po mahirap bigyan ng vaccine ang ating N. gonorrhea kasi they have antigenic variation of its pili. 50. An 18-year-old female sought consult for a 3-day history of high fever, retroorbital pain, and muscle pain. During her admission, she developed rashes resembling isles of white in a sea of red shortly after her fever lies. What test will provide the most reliable evidence of an active infection? Now, this is a case of dengue. Very obvious naman, we have your high fever, retroorbital pain, and muscle pain. And definitely, nagkaroon ka ng isles of white in a sea of red after lysis of fever. Na ang tanong dito ay, paano mo masasabi na meron kang active infection? Now, the best here is to have an analysis of paired acute and convalescent sera because viral isolation is difficult. Therefore, A to C is not that reliable for diagnosis of dengue. Okay, and per Jowetz, sinabi niya that the most reliable will still be your paired acute and convalescent sera increase in titer. 51. The release of viral progeny from cells infected with influenza virus is mediated by which of the following? Now, kapag lumalabas ng ating influenza virus from the infected cell, kailangan niya ng neuraminidase. Okay, that is the important mediator. Pero kapag gustong i-invade the influenza virus ang isang cell, kailangan niya ng hemagglutinin. Okay? So to simplify things, hemagglutinin is for entry. Hemagglutinin, entry. Neuraminidase, exit. To exit the infected cell. 52. Which of the following pairs of parasites and their corresponding vectors is incorrectly matched? The correct answer is C. Brugia malayi culex. Tama ang ating Chrysops and Loa-Loa. Tama ang Simulium or black fly for Onchocerca volvulus. And tama rin ang ating Anopheles for Wuchereria bancrofti. Mali ang ating Brugia malayi. It should be Mansonia, not culex. Now, for your lymphatic filariasis, take note that Aedes, Anopheles, and Culex can be the vectors of your Wuchereria bancrofti. But Mansonia is the only vector of Brugia malayi. Mansonia malayi. Mama. Mansonia malayi. 53. An ID fellow is interested to cultivate Leptospira species for his research. which of the following culture media can be used to isolate the organism? Okay, ito, it's more of rote learning. So, ang tamang sagot dyan ay Fletcher medium. It is the medium used to culture leptospira organisms. But in some cases, you may also use this kind of medium known as Ellinghausen, McCullough, Johnson, Harris, agar, also known as your EMGH agar. So take note guys, TCBS agar for Vibrio, buffered charcoal yeast extract agar for Legionella, and CIN agar for your Yersinia enterocolitica. CIN agar, Yersinia enterocolitica. So number 54, an unknown isolate of gram-positive cocci was found to be beta-hemolytic on blood agar. Testing showed positivity to heparate hydrolysis but negative to catalase and is resistant to bacitracin. An arrowhead zone of hemolysis was seen when it was inoculated perpendicular to S. aureus streak. What is the most likely organism in this case? So dahil meron kang catalase negativity, malamang sa malamang hindi siya staph na organism. It should be under Streptococcus. And dahil meron kang beta-hemolytic on agar at meron kang arrowhead zone of hemolysis known as camp factor positivity, on top of having heparate hydrolysis, mukhang siyang case ng S. agalactiae. Okay, S. agalactiae is the correct answer in this question. S. agalactiae is also known as your group B Streptococcus per Lancefield classification. Okay, it's a risk factor for preterm labor among pregnant patients and moreover can also cause neonatal sepsis. 55. A 16-year-old high school student developed fever, abdominal cramps, and bloody diarrhea 3 days after coming home from a camping trip. Nagpa-culture sila, may lumabas na non-lactose fermenting, non-motile, oxidase negative rods. What is the most likely organism? So in this case, it's a GI problem. Tango sabi niya, non-lactose fermenting. So have the following at the back of your head. Baka Salmonella, baka Shigella, baka Pseudomonas. But take note na oxidase negative siya. So therefore, malabo na Pseudomonas natin because Pseudomonas is an oxidase positive organism. So you only have Salmonella and Shigella. And to differentiate them, you check their motility. Kasi ang Salmonella ay motile while Shigella is a non-motile organism. Therefore, highly likely this could be a case of Shigella organism. And the correct answer here would be A. Since Shigella is negative for H2S formation on XLD agar. Now, the others are wrong because Shigella has a low infectious dose, meaning konting organism lang ang kailangan niya and yun na ang enough para mag-cause ng sakit. Ganun siya kasimple. And mucoid colonies are not seen in these organisms. Usually, they're seen in Klebsiella among other members of the Enterobacteriaceae family. They ferment glucose, but they do not produce gas formation. 56. Which of the following fungal organisms does not exhibit thermal dimorphism? Thermal dimorphism only exists in endemic or systemic mycoses and in sporetric Schenki. So, meron yun sa ating Schenki, meron yun sa ating Histoplasma and Coccidoides kasi BNC are both endemic or systemic mycoses. Therefore, the correct answer here is D, Malassezia furfur. Always remember guys, mold in the cold, yeast in the heat. Mold form room temperature, yeast form body temperature. And dimorphic fungal are your endemic or systemic mycoses and your sporotrix Schenki organism, a form of subcutaneous mycosis causing fungal organism. 57. What is the infective stage of Toxoplasma gondii? Correct answer is dog, all of the above. Okay? Kasi guys, our Toxoplasma has different modes of transmission. Okay, if it's undercooked meat, diba, baka makain mo yung mga tachyzoids, mga bradyzoid, ba? If biocontaminated water, baka mga OOCs makuha mo doon. And of course, transplacental, organ transplantation, you can get all of them. So all of them are actually infective stages for Toxoplasma gondii. 58. A 30-year-old female seeks consult for a lump in the groin. On examination, there were multiple small painless papules in the genital area with beefy red ulcers that have velvety surface. Samples were taken and will most likely reveal blank. So in this case, guys, if you're talking about genital ulcers, always think about kung painful ba siya or painless sila. Kasi pag ang usapan ay painless ulcer, think of three things. Painless ulcer from syphilis, primary syphilis, chancre. Painless ulcer from donovanosis, also known as granuloma inguinale. Or a painless ulcer but painful lymphadenopathy for a case of lymphogranuloma venereum. In this case, ang kwento meron siyang beefy red ulcer. And among them, there is actually a distinct characteristic of your donovanosis, also known as granuloma inguinale, which is caused by Klebsiella granulomatis. And this organism presents as a bipolar density that looks like closed safety pins. Okay, so these are genital ulcers. As mentioned, you have two na painless ang ating ulcers na major. Okay, treponema sa Klebsiella. Ang third ay painless din ang ulcer niya, pero painful ang kanyang lymphadenopathy. That is her LGV, being caused by chlamydia trachomatis L1 to L3 serotypes. Ang syphilis, ang chancre ay solitary raised ulcer. So hindi siya ang sagot kanina. Ang Klebsiella ay red and beefy base. Pag-uusapan ay painful ulcers, always think of two, herpes saka chancroid. Guys, herpes simplex viruses. Pag chancroid, cry, masakit, di ba? Having multiple excavated ulcers with ragged, irregular edges. Now, in the case kanina, the options, kapag helically coiled organisms, think of Respirochetes or Treponema pallidum, for example. Pag school of fish of gram-negative rods, always think of Haemophilus ducreyi. Pag multinucleated giant cells, always think of your herpes viruses. 59. What is the agent causing your cat scratch disease? It is your A. Bartonella henselae. B. Is the infection from animal bites, Pasteurella multocida. C. Erysipelotrix russopatiae is for erysipeloids, and your dog Coxiella burnetii is for your Q fever. And it can also cause your culture-negative infectious endocarditis. Last but not the least, 60 for microbiology, Staphylococcus aureus harbors multiple virulence factors that have immunomodulatory function. Which of the following factors prevents complement activation? It is your protein A. Ang catalase, as mentioned, it detoxifies hydrogen peroxide. Okay, if your catalase positive, matik yan, baka ikaw ay Staphylococcus to organism. Panton valentine leukocidin, from its name pa lang, leukocidin, it destroys leukocytes. TSST1 is a form of super antigen. Ang mga super antigens natin, they bypass antigen presentation via your macrophages and dendritic cells. The antigen itself, para siyang Superman, it directly attacks the T cell and activate the T cells. And these T cells will then cause a cytokine storm, causing shock as a presentation. In our case, TSST1 can present as toxic shock syndrome. Okay? That is your super antigen. Directly activates your T cells, leading to a cytokine storm. While protein A prevents your complement activation. And that is all for your microbiology and your parasitology. Okay. Now, we're heading to your physiology. The first exam for your day 2. Okay? Now, number 61. Secretion of hydrogen ions into the gastric lumen will utilize which transport mechanism? It's a two-step question. Una, ano ba ang transport system involved in this phenomenon? That is your H-potassium ATPase. Guys, always remember, if you have ATP sa pangalan ng transporter, that is most likely a primary active transport. So tanggal na si C, saka si D. Pag may nabasa kang sodium sa iyong transport name, saka siya magiging secondary active transport system. Okay, klaro yun ha? Na ang tanong dyan, ano bang movement ng ating sodium, ano bang movement ng ating hydrogen tsaka potassium? In this case, hydrogen goes into the lumen while potassium goes into the parietal cell. Therefore, antiport ang kanyang system. Correct answer is B, primary active transport, antiport system siya. Okay? As you can see guys, choice C, good example is sodium potassium 2Cl symport. And dog is a sodium hydrogen exchanger. Both of them are may sodium. Therefore, most likely, they are a secondary active transport system. 62. Which contributes the most to the negative 70 millivolts resting membrane potential of neurons? Correct answer is A, nurse potential for sodium and potassium. Ang C natin may contribute, but very, very minimal. Only around 4 millivolts lang siya. Therefore, it is a weak contributor. Ang ating action potential is only a distractor. Action potential does not contribute to the RMP. But changes in the resting membrane potential can trigger an action potential via the all or none response. Okay? Take note of that concept. 63. Hidilyn Diaz probably has a greater percentage of this type of extrafusal muscle fiber. Now, una, ano ba si Hidilyn Diaz? She is a very known weightlifter. Ang weightlifter, kailangan nila ng acute, short use of burst of energy. Okay, so have that at the back of your head muna. Now, let's check your choices. Ang sabi, extrafusal muscle fiber ang hinahanap mo. So that could be C or D. Kasi extrafusal refers to your usual skeletal muscle fiber. Ang iyong muscle spindle, hindi yan yun. Kasi ang muscle spindle ay is also known as intrafusal muscle fiber. Okay, so hindi siya extrafusal. Multi-unit is used for smooth muscles. So, hindi siya ang ating option, leaving you with only C and D. But in this case, you must need here a type 2 muscle fiber. Kasi, Hidilyn Diaz sport is weightlifting, requiring power more than endurance. Okay? And type 2 fibers are needed for weight resistance and training, for sprinting. Kasi, they use anaerobic glycolysis. And this form of glycolysis may only perform minimal effort, pero can provide large amounts of power para hindi pang matagalan. Okay? Kaya siya white kasi it's predominantly contains glycogen at konti ang kanilang mitochondria and myoglobin. It makes sense. Bakit? Kasi myoglobin contains heme protein. Heme protein is color red. Therefore, if less ang iyong myoglobin, less ang iyong pagiging red. Mas pale ka in color. At konti ang iyong myoglobin kasi hindi ka naman nangangailangan ng oxygen for anaerobic glycolysis. In contrast for type 1, okay, for type 1 guys, always think of a 1 slow red ox. Mas ginagamit to for endurance training kasi ang kanyang major mechanism for Metabolism ay oxidative phosphorylation, allowing sustained contraction. Actually, unlimited nga yan as long as you have the enough substrate and nutrients. So in this case, ikaw ay red. Bakit? Kasi you have lots of myoglobin and mitochondria. You have myoglobin, just color red. Kasi it is the form needed for storage of oxygen. Okay? Now, you have mitochondria kasi mitochondria is the site for oxidative phosphorylation. So, hence, kailangan mo ang type 1 for endurance training. For marathons. 64. Mavi panicked when he saw Celis about to be hit by a truck while crossing Commonwealth Avenue. He rushed to save her. Which among the following do you expect to happen the least to Mavi? Alin dyan yung hindi mo in-expect mangyari? Okay, so in this case, Mavi, nagpanic siya. Okay, he is exhibiting here a form of fight or flight response seen in the sympathetic nervous system. Therefore, okay, tama si A, midriasis. Midriasis, the D here means dilation. You have pupillary dilation. Kailangan malaki mata mo para makita mo yung environment. So check, kailangan siya. Pag ikaw ay under stress. If under stress ka, kinakabahan ka, you have tachycardia, ikaw ay pinagpapawisan. So by add man out, guys, you have B already. And tama naman, di ba? If we're stressed, if we're going to fight someone, di ba, or flight, you have to have the energy. Kaya hinihingal ka eh. If ikaw ay bronchoconstricted, baka hindi ka makahinga properly. Kailangan dilated ka para ikaw ay makahingal malalim. Okay? So, kailangan bronchodilation to if ikaw ay sympathetic nervous system. Okay? Remember guys, don't forget your fight or flight responses. 65. Ito is more of a recall question. Which of the following is correctly matched to the nerve fiber? Correct answer is boy. Preganglionic autonomic fibers is type B. A is incorrect. Kasi dapat, yung mga proprioceptors mo, the muscle spindles and Golgi tendon organ should be type 1 alpha, not delta. C, fast pain should be A delta. Should be type A delta. Pag slow pain ka, siya magiging type C. Smell should be a type C phenomenon. Rather, the type C nerve fiber. So, mali ang ating smell dito. Leaving us with B as the correct answer. So, pag preganglionic ka, na autonomic fiber, dapat type B ang fiber natin. Pero pag ikaw ay postganglionic, saka ka magiging type C ulit. Now, you have to recall this table, guys. It's testable. But in terms of thread, always take note that the larger the diameter of a nerve, the faster the conduction velocity. The more myelinated the nerve, the faster the conduction velocity. 66. Comparing Manny Pacquiao and Manny Pangilinan, what should we expect in terms of their cardiovascular characteristics? Correct answer is A. Pacman would have a lower resting heart rate than Manny Pangilinan. Kasi among athletics, they have usually a bigger heart. Okay? If you have a bigger heart, malakas na ang iyong stroke volume already. Okay, recall the formula of your cardiac output. It's stroke volume times heart rate. If mataas ang stroke volume mo, mataas ang cardiac output mo na. Definitely. Therefore, hindi mo sobrang kailangan ng mataas na heart rate to compensate. So, you will have a lower heart rate relatively at rest. Now, mali ang ating boy kasi both athletes and non-athletes have the same cardiac output at rest. Nagabago lang sila kapag ikaw ay merong exercise. Mali si C kasi maximal cardiac output is higher for athletes. And dog would be wrong kasi dapat most of your blood will be at the veins. Okay? The most of your blood volume is always at the veins. Okay? So mali ang capillaries natin. Recall guys, your formula for cardiac output. Heart rate times stroke volume. And cardiac output should be equal to venous return. If there is a mismatch between your venous return and cardiac output, you will have what we call heart failure. 67. Aortic pressure is highest during this phase of the cardiac cycle. It is between your rapid and reduced ventricular ejection. Okay, as you can see in the Wigger diagram here, this is the highest part of your aortic pressure. Okay, this one. Right? Okay, and this aortic pressure na yan, yun siya pinakamataas, di ba? It's found between the rapid ejection phase and the reduced ejection phase. Nasa gitna talaga siya. So that is the correct answer here. Now, there is an error daw in physio-BRS kasi sa physio-BRS, hindi niya sinabi kung start or end siya. Ang sinabi lang niya ay reduced ventricular ejection. So in the exam, kapag ang lumabas ay walang option na between rapid and reduced ventricular ejection, simply answer reduced na lang. Kasi that is the answer key of physio-BRS. Okay? 68. What is the site of aldosterone secretion? Now, to answer this, guys, you have two mnemonics here. Ang una ay GFR for your zona layers of your adrenal cortex. GFR, meaning GFR, G ang pinaka-superficial, F ang gitna, R ang pinaka-deepest. Okay, ang ating medalla is always found inside the adrenal gland. Okay? Now, dahil alam mo na yan, malalaman mo na yung site ng ating aldosterone secretion, which is the A. Kasi, ang mnemonic na isa pa ay, the deeper you go, the sweeter it gets. At the glomerulus level, it's all about saltiness. So that's your mineralocorticoid. Sweet ang ating cortisol. Kasi cortisol is a glucocorticoid. Now, sex daw ang pinaka-sweetest. Kaya it involves weak androgens. And take note, guys, syempre, ang ating medalla, it secretes 80% epinephrine and 20% norepinephrine. Don't forget this value. It's very testable. 69. In a normal healthy male, what percentage of the tidal volume can undergo gas exchange? Now, to answer this, guys, you have to know your normal tidal volume. It is 500 ml. And also, take note that the anatomic dead space is 150 ml. Ano ba ang ating anatomic dead space? Ito yung part ng ating tidal volume na non-functional. It does not participate in gas exchange. So, to get the functional tidal volume, the one involving in gas exchange, you must subtract 150 ml from 500 ml, yielding a value of 350. Now, to know if gaano karami yung functional tidal volume, so you must have the formula 350 divided by 500 times 100, yielding a value of 70%. Okay, so that is the correct answer in this question. 70. What happens to FEV1, FVC, FEV1 over FVC, and FRC respectively in COPD? Correct answer is DOG. FEV1, FVC, and FEV1 over FVC is decreased. However, FRC is increased. Now, COPD is a type of obstructive lung disease, along with your bronchial asthma, bronchiectasis, and your bronchiolitis. Now, the other type of lung disease known as restrictive lung disease. Andiyan ang ating fibrosis and even pneumonia. Now, both FEV1 and FVC of obstructive and restrictive are both decreased. Pero nagbabago lang sila mainly in the ratio and in the FRC. In terms of ratio of FEV1 over FVC for the obstructive lung diseases, it is always decreased kasi mas mataas ang decrease of magnitude the FEV1, the numerator, than FVC, which is the denominator. So when you compute it mathematically, mababang yung FEV1 or FVC. Now, pag-uusapan ay restrictive lung diseases, usually of the same magnitude yung pag-decrease ni FEV1 at ni FVC. So usually, normal siya. Okay? Normal siya usually. It is not decrease. That's the point in this table. Now, bakit mataas ang FRC in obstructive lung diseases? Now, it is because of the concept known as air trapping. Okay, for example, in COPD patients, you have air trapping, you have emphysema, di ba? Kapag pumasok ang air sa iyong lungs, madali lang yun. Pero mahirap siya lumabas because of what we call the ball valve effect. Okay, hindi makaangat yung ating air kasi na-trap siya via this mechanism. If you have air trapping, lalaki ang yung lungs in the process. Therefore, you will have a higher functional residual capacity. Mataas ang na-residual mo na lung volume, na air sa yung lungs. Now, in restrictive ILD, you will have a decrease in FRC. Recall, you have fibrosis, di ba? You have fibrosis, hindi maka-expand ang lung mo properly. Therefore, you have an overall decrease in total lung capacity. If hindi maka-increase ang yung lungs, it means konti lang ang nare-retain na air in your lungs. Therefore, you have a lower functional residual capacity. 71. VQ ratio is highest in the apex of the lungs. And it is clinically important, especially in reactivation of M. tuberculosis. Bakit? Kasi in MTB, we know that this is a very strong aerobic organism, ang tuberculosis na Mycobacterium. So it wants to go to the place of the lungs na merong mataas na VQ ratio, and that is your apex. Kaya in secondary TB or reactivation TB, there will be the prominence of apical infiltrates in the chest X-ray. So yun ang rationale behind that because apex has the highest VQ ratio. 72, this is more of a recall question, which is correctly matched to its volume marker. It is your plasma and RISA. Now, both RISA and also Evans blue can be used as a marker for plasma. Okay? Take note of that. Now, ang din natin, IF. It cannot be directly, competed yung ating interstitial fluid kasi it's usually extracellular fluid minus the plasma volume. Okay? So, hindi mo siya basta-basta mako-compute. So, yan guys, you have to know this table. It's very important. Okay, this can be asked in the PLE. 73. Ampi, a 25-year-old female, drank 1 liter of distilled water, while Riza drank 26, had massive sweating pala after a 10-kilometer run. So, yung isa, punong-puno ng tubig. Isa naman, walang tubig. So, what is expected? Riza would have a much bigger ECF volume? Hindi. Bakit? Kasi marami na siyang na-sweat, diba? So, konti ang kanyang ECF volume. So, mali si A natin. Ampi is expected to urinate less compared to Riza. Wrong. Mas maraming iihi si Ampi kasi marami ang kanyang water. Meron siyang excess water. Si Riza, hindi iihi masyado yan kasi marami siyang sinuwet. So, si Riza dapat ang merong less na urination. Ampi is expected to have a higher ECF osmolarity. Wrong. Kasi mas diluted ang fluids ni Ampi. Kasi nag-take siya ng excess na free water. Therefore, magkakaroon siya ng lower na ECF osmolarity. Madadilute ang kanyang sodium at ang kanyang ibang mga solutes. Now, yung B, para mahirap siya sa unang pakinggan, but is actually the correct answer here. So, even by testmanship, you can answer this question. Siya ang expected. Kasi, this is governed by your glomerulo-tubular balance feedback. Okay, ano ba yan? This feedback states that percentage of solute reabsorbed is held constant. It buffers effects of drastic GFR changes on urine output. Guys, in the question, guys, it's about what? It's about the percentage. Okay, it's not about the absolute value. So, B is still the correct answer here. Kasi, ang sabi nga ng ating glomerulotubular balance, it is the percentage of solute that is held constant. Okay? 74. Which of the following formulas is correct? Correct answer here is B. The one about renal clearance. Okay? It should be U times V over P. Now, ano ba yan? Your U here is urine concentration. V here is urine volume over time. While P is the plasma concentration. Mali ang ating A kasi dapat GFR ang ating numerator while RPF is our denominator. Mali ang C kasi dapat meron kang concentration change, C1 minus C2. At mali si D kasi dapat Q ang nasa numerator at A or area ang ating denominator. Okay? Guys, for this, my best tip, recall these equations, especially before the exam of physio. Okay? 75. Inner circular and outer longitudinal muscle layers are innervated by the auerbach plexus, also known as your myenteric plexus. Okay? It's mainly for motility. Okay? Kasi the auerbach plexus innervates your muscularis propria or muscularis externa. In contrast, your masseter plexus, also known as submucosal plexus, ang ginagawa niya, it innervates the muscularis mucosae, the one found in the mucosa, and that muscle is mainly for secretion and absorption. Now, ano ang C natin? Pacemakers of the GI tract are your interstitial cells of Kajal. Take note of that concept. 76. The main trigger for CCK secretion is fatty acids. Okay? Guys, cholecystokinin, ano ba nangyayari dyan? In cholecystokinin, ang kanyang function is to the contraction of your gallbladder and the opening of your biliary tracts para mag-release ng bile in response to fatty acids. Kasi bile will cause fat emulsification. Therefore, fatty acids is the best stimulant for CCK increase. Now, that is also the rationale why you have pain if you have gallstone disease, kasi pag kumain ka ng fatty meal na heavy, kasi those fatty acids will cause contraction of the gallbladder. At if may stone ka sa loob, syempre masakit yun sa iyong interior wall ng iyong gallbladder, causing right upper quadrant pain. Okay guys, take note also of the triggers of other hormones. Fasting for motilin, to trigger your migrating motor complexes. Amino acids, phenylalanine, tryptophan, and methionine can trigger gastrin in the process. And glucose can trigger GIP and GLP. Those are actually insulin secretagogues. 77. Which GI cell secretes histamine? The correct answer is D, your ECL or enterochromaffin-like cells. Okay? Dok, ano yung mga yan? Oxyntic cells are your parietal cells, which secretes HCl and intrinsic factor. While Kulczycki cells are also known as enterochromaffin cells. Dok, wait lang. You have ECL. You also have enterochromaffin cells. Guys, they're different. Ang ECL mo makes histamine. Ang EC cells mo makes serotonin. So take note of this differentiating factor. Lastly, your zymogenic cells, also known as sheep cells or peptic cells, release pepsinogen. Okay? The pepsinogen is the immature form of your pepsin. 78. What characterizes T3 in comparison to T4? So you have two major hormones from the thyroid gland. Thyroxine T4 and T3 your triiodothyronine. Laging mas marami si T4. So mali si A dito. Pero mas active si T3. Hence, B is the correct answer here. Okay? So this is a good table about T4 and T3. Mas marami lagi si T4. and has a higher half-life. Pero mas active si T3 natin. Has a faster onset of action and binds to nuclear receptors. Okay? 79. Sa form of recall question, average viability of sperm is 3 days, while eggs naman are 1 day. Okay? Take note of this. Ang point lang yan, you only have a very small room for fertilization to occur. Kasi you only have 1 day for an egg cell. So, ganyan ka-toxic magkaroon ng baby. Okay? 80. Last but not the least, for physiology, which antibody fixes the complement? It's your B, IgG, and IgM. Ang IgA rarely fixes the complements, okay? But it is the major immunoglobulin produced by the body overall. Pag ang usapan ay major IG in the serum, it's your IgG, okay? And IgG is the only one capable of crossing the placenta. Okay, more pearls, IgM, siya ang primary na immunoglobulin for the primary immune response. Pag secondary immune response, it's mainly IgG na. IgM and IgD are those found in the naive B cells. IgE is found in hypersensitivity reactions. While IgD, besides being found on the surface of naive B cells, along with IgM, it also has a function for immunomodulation. Okay, so that's all for physiology.